Hi everyone, thanks for joining me on another tutorial. Today we're going to go over hyperkalemia. What that will entail today is we're going to go over the fluid compartments and also potassium physiology. We'll cover the causes of a hyperkalemia and what that looks like in our patients. That's the clinical manifestations. Lastly, as hyperkalemia can be a medical emergency and a life-threatening condition, we'll cover the management and what's essential to know about treating hyperkalemia. So before we delve into the details of hyperkalemia, it's first important for us to understand how fluids are distributed across the body. So in a 70 kg person, around 60% of the weight is from water, and that's about 40 liters. So the total body water can actually be split into different compartments, and that is either intracellularly, so within cells, or extracellularly, outside of cells. Within cells, there's about 2/3 of that total body water. So in this case, that's about 25 liters. The remaining 15 liters is in the extracellular fluid, and that is comprised of the plasma, the blood plasma, so found inside our blood vessels and vascular system, and that represents about 1/4 of that remaining 15 liters, and the remaining 3/4 is in the interstitial fluid, so that is between cells and between tissue. So it's important to note that actually these fluid compartments, while they seem like they're kind of discrete entities here, actually fluid can travel backwards and forwards from here. And that is what allows electrolytes and water to shift and diffuse between them depending on things such as the osmotic pressure. Lastly, it's important to note that the levels of potassium are very high intracellularly. So intracellularly, we have a lot of potassium. And this intracellular potassium is very tightly regulated, as it is what determines the resting membrane potential of cells that generate action potentials. And that's particularly important for cardiac pacemaker cells or cardiac cells in general. And that is why the dysregulation of potassium can lead to fatal cardiac arrhythmias, which we will talk about. So what are the causes of hyperkalemia? Well, in general, with any electrolyte deficiency, we can classify them into 3 branches. The first one is decreased intake, though this is quite uncommon because potassium is relatively ubiquitous in diets. We can have decreased excretion, and this is important in patients with acute or chronic kidney disease. So we'll say acute kidney injury or chronic kidney disease. And lastly, and the most interesting one in my opinion, is intracellular shifts. And just like we said earlier, electrolytes are free to move between cells, inside cells, like those fluid compartments. And there's 3 important causes of intracellular shifts that we're going to talk about. And you'll notice that I've drawn a little membrane here, and we're going to just label this as the outside of the cell. And we'll label this as the inside, and this is a cell membrane. So inside the cell, we have lots of potassium. That should be 1+. We have lots of potassium here. We have relatively little outside of the cell. So the 3 causes of intracellular shifts is firstly acidemia. So when we have a low blood pH, that is too much acid in the blood or outside of the cell, this acid, which we will put in blue, we'll put in purple, this acid wants to try and go down its concentration gradient away from this area of high concentration, and it swaps with the potassium inside of the cell. So what you'll find is that in essence the potassium comes out and the hydrogen ions, we'll do that in the same color, the hydrogen ions or the acid comes in. So this is the first cause of a hyperkalemia. With a significant acidosis or acidemia, you will get an increase in the serum or the blood potassium. Now, the second cause of the intracellular shift is a decrease in insulin. So insulin deficiency. And what insulin normally does is it actually facilitates the entry of potassium into cells. So if you have an absence of the insulin, plasma potassium or serum potassium will rise. And lastly, beta blockers, a very common medication. So beta blockers, they decrease the adrenergic activity of the body. And what in essence that does is, if you remember our NAK ATPase, which sits here in the membrane, what it does is it helps to shift potassium inside the cell, potassium in and then sodium out. And beta adrenergic activity or adrenaline, those serve to increase the activity of this membrane. And so if you block that activity, or if you decrease that activity, then you're going to get less shifting of potassium inside the cells, and therefore more potassium is going to be left outside of the cells. And so the three causes again are acidemia, and the best way to think about that is that essentially the hydrogen ions are swapped for the potassium. And if you remember that potassium is high inside the cell, that'll kind of stick. So we have acidemia, we have a decrease in insulin, and lastly, we have beta blockers. So we know now how potassium or hyperkalemia can occur, but what does this mean for our patients and how do they actually present? Well, typically patients with hyperkalemia are usually asymptomatic, and they're usually asymptomatic unless their potassium is over 7. Now, that's just a general rule, and some patients may develop symptoms earlier, they may develop symptoms later. It really does vary. But in general, they're asymptomatic until a fairly high serum potassium. The signs or symptoms that they may develop include nausea, muscle weakness, and eventually that weakness turns into an ascending paralysis. Now, lastly, the most kind of concerning and life-threatening complication of a hyperkalemia is cardiac arrhythmias. And, oh my god, if I could spell cardiac arrhythmias. That's also, arrhythmia is a very tricky word to spell. So in general, cardiac arrhythmias are what we're going to be looking for in any cardiac involvement. And we're now going to talk about what the changes are, or what the electrocardiographic changes are with a hyperkalemia. And I like to use a mnemonic called the Hyperkalaemia box, which helps to explain the causes that we're going to talk about now. So if you remember your ECG, well, in no particular order, what tends to happen is you get an increased T waves, you get prolonging of the PR interval, eventually you lose your P waves, you drop the P waves, you get a prolonging of the QRS complex, and then eventually you get a sine wave, which is very not good, and that patient is very likely having a cardiac arrest. So these are the 5 kind of key takeaways, and they may not be present sequentially, but in general you'll see some peaked T waves, the PR prolongs, you get a decrease or you drop the P waves, decrease or drop, the QRS complex prolongs or widens, I should say, widens, and then a sine wave arrhythmia and arrhythmia. That really does look essentially like that on the ECG. Now I've just got here an ECG, a de-identified ECG, just to kind of show, if you want to pause the video and have a guess as to what abnormality is here. I'll give you 3 seconds. 3, 2, 1, and quite clearly here you can see some tall tented T waves, and you can see them pretty much through all of these leads here. And a good way to think about that is that if you would see a T wave and it would hurt to sit on, then that's a good indication that they might be tented T waves, tall tented T waves. So now that we've identified a hyperkalemia, how exactly do we treat a patient's hyperkalemia? So the management falls very broadly into 5 aspects. Firstly, the most important thing is to stabilize the myocardium. And the myocardium is the heart muscles, the heart cells, and these are the ones that will cause a life-threatening arrhythmia, and that's the most life-threatening complication. And so the first step is to stabilize them. Then we want to shift the potassium, and we typically like to shift the potassium intracellularly, where there's high, the cells can tolerate a higher potassium. Then we're going to remove the potassium, and we remove from the body. 4, we're going to monitor. And that's the last step, is to monitor what the potassium does after we implement our management. So with number 1, stabilizing the myocardium, the most important molecule is calcium. And we give calcium in 2 forms. We can either give it in calcium chloride or calcium gluconate. You'll find that the doses of these medications vary, and it does. There's a difference in whether the patient has having a cardiac arrest, where the doses might be higher, or if the potassium just has. There's only just some ECG changes, and the patient is asymptomatic. So there's really an escalation in how much of these you give, but the most important thing to remember is that calcium stabilizes the myocardium. Not like that, like that. Stabilize the myocardium. And if you were looking for a number, I'll give you a number. It's essentially 10 mils of 10% calcium chloride, and that's the arrest dose to stabilize the myocardium. Excellent. Now, how do we shift the potassium? Well, we talked earlier about the causes of a hyperkalemia being acidemia. The second was an insulin deficiency. And then the third one was adrenergic effect, blocking adrenergic activity. So essentially, we're going to do the opposite of those 3 things. So we can give a patient insulin and dextrose to make sure they don't become hypoglycemic. And essentially what you're going to give them is 10 units of a short-acting insulin, let's just say Novorapid, with some dextrose running. The second option is that you can give them some beta-adrenergic or beta-2 adrenergic agonists, and the most commonly used one is salbutamol. And remember, there's a few mechanisms, but the one I want you to kind of remember is it's going to increase the activity of the several cellular transporters like the sodium potassium ATPase, and that's going to drive more potassium into the cell. And this can be given either nebulized, it can be given intravenous, any manner of giving. And the last thing we're going to do is to prevent or try and treat an acidemia or acidosis. We're going to give them the opposite, which in our case is bicarbonate, and we can give them some HCO3 minus in the form of sodium bicarbonate. sodium bicarb. Good. And lastly, how are we going to remove potassium from the body? Well, we can remove potassium in the urine with loop diuretics. Oh, if I can spell it correctly. Diuretics. And the reason we use loop diuretics is because they block that in the ascending tubule. They block the triple co-transporters, and they'll have the greatest washout of your electrolytes like potassium. So you can actually find that patients on these diuretics naturally get a bit of a hypokalemia, and in this instance we can use that to our advantage. If you can't really recall your renal physiology, I'll put a link to my previous video where I just talk about the effects of diuretics and how they interact with the renal tubules. So we can give them some loop diuretics. Secondly, we can excrete it in the stool, and that's with stool/GI binders. And the most common one you'll see is rhizonium. And what that does is it binds potassium in the diet, in the gut, and it prevents it from being absorbed in the first place, and that way you won't see such an increase in the serum potassium if they've had just a ton of, I don't know, bananas or something. And lastly, the last ditch attempt, if someone's got a very high potassium and the above are not working and they're still in danger of an arrhythmia, then you just give them, you dialyze them. Do I even know how to spell dialysis? So you essentially have to remove the potassium from the blood itself, which is no easy process, and these patients will essentially need transfer to an intensive care unit for not only the dialysis itself, but monitoring of their potassium. And that wraps up our video on hyperkalemia. Thank you guys for joining me. I hope you have learnt a little bit, taken away something, especially that hyperkalemia box. That has, saved me in front of consultants every time I'm getting questioned on it. I hope it's been useful, and I'll see you guys next time. Thanks for listening.